Hello all, we are continuing with MRCP Part 1 sample questions. Question 121. A 44-year-old man presented with a 2-month history of sores in his mouth and nose and a 10-day history of blisters on his scalp and back. On examination, there were flaccid bullae and erosions on his scalp and back. There were erosions of the oral and nasal mucosa. Pending results of a skin biopsy, what is the most appropriate empirical treatment? So we are asked, there are bullous lesions, okay, flaccid bullae and erosions on scalp and back, and also mucosal lesions in the oral and nasal mucosa as well. This of 2-month history. So we have to first identify the diagnosis. So they are talking about pemphigus vulgaris. Pemphigus vulgaris. So this pemphigus vulgaris, what do you give? Is it acyclovir, itraconazole? No treatment required. Phenoxymethylpenicillin, prednisolone. So we give steroid for pemphigus. So it is prednisolone for pemphigus vulgaris. I'll just try to highlight what is the difference between pemphigus and pemphigoid. Pemphigus, commonly called pemphigus vulgaris. Pemphigoid is your bullous pemphigoid. Appearance is this like scaly lesions, and in pemphigus it can be seen in the back. Okay, bullous pemphigoid is bullae-like lesion, bullous lesions. Okay, in pemphigus it is usually present in younger age group, bullous pemphigoid in older, and mucosal membrane involvement is seen in pemphigus vulgaris, not in bullous pemphigoid. That is one of the highlighting difference between the two, because in question, if there is involvement of mucosa or oral and nasal mucosal lesions, you have to think of pemphigus and not pemphigoid. Antibodies seen in pemphigus is against desmoglein 3, and in bullous pemphigoid is hemidesmosomes. And the blisters are intraepidermal or superficial, but in bullous pemphigoid it is subepidermal, it's more deep. And the blister is flaccid and they rupture easily in pemphigus vulgaris, but they're tense and firm in bullous pemphigoid. And that is why in pemphigus vulgaris there is Nikolsky's sign. Nikolsky's sign means once you rub the lesion or you try to touch the lesion, the skin peels off. That is what you see here. That's called Nikolsky's sign, but that is negative in bullous pemphigoid because the blisters there is more tense and firm. They do not rupture easily and the skin does not peel off easily. Prognosis is poor in pemphigus and it is better in bullous. So remember, bullous pemphigoid do not have oral lesions. Nikolsky's sign is positive in pemphigus vulgaris, and antibodies in pemphigus it is against desmoglein 3, and it is more superficial than bullous pemphigoid. Next question, a 57-year-old woman with long-standing rheumatoid arthritis presented with 5-day history of severe pain in her right eye. So it is rheumatoid arthritis and eye pain. So rheumatoid arthritis can have manifestations, rheumatological conditions can have eye manifestations like uveitis in some, scleritis, episcleritis, but here there is pain also. So you have to think of any of these. The pain radiated to the frontal region, face, and was worse at night. On examination, her right eye was red with normal visual acuity and fundal appearance. What is the most likely cause of her pain? Options: acute anterior uveitis, acute glaucoma, conjunctivitis, scleritis, subconjunctival hemorrhage. So usually associated things are episcleritis and scleritis. Episcleritis is less painful, usually does not have pain. Scleritis is highly painful and can present with a red eye. Okay. Uveitis usually associated with your ulcerative colitis and all, and there can be hyphema in the anterior chamber. The cells settle, and that's called a hyphema. Usually that will be mentioned in the question. So it is not uveitis. Glaucoma, no. Usual association of rheumatoid arthritis, you have to understand in this setting, more likely causes scleritis, okay, than an infective conjunctivitis and all. So it is scleritis. Next question. A 65-year-old man who was undergoing investigations for tinnitus was found to have a small intracellular pituitary lesion measuring 0.9 centimeter. Investigation showed no evidence of pituitary hormone excess. A repeat MR scan of brain 1 year later showed no change. What is the most likely clinical consequence of this lesion? So here, initial investigation showed no evidence of pituitary hormone excess. So pituitary lesion, most common mass is a pituitary adenoma, and that can be a non-functioning adenoma also. So here also no evidence of pituitary hormone excess means it's a non-functioning adenoma, and there is no change in size a year later. So the consequence is none. No clinical consequence will be there because there is no pituitary hormone. This can be a non-functioning pituitary adenoma. Next question, a 56-year-old man with chronic kidney disease stage 4 secondary to chronic glomerulonephritis was seen in the outpatients clinic. Investigation showed calcium 1.85 normal, or it is low. Okay, 2.2 to 2.6 is normal, so it is low. Serum phosphate 1.8, it's high. Serum alkaline phosphatase 156 high. Plasma parathyroid hormone 32.7 high. What is the most likely cause of hypocalcemia? So here calcium is low, phosphate is high, parathormone is high, ALP is high, and the man is having CKD stage 4. So in CKD stage 4, there can be vitamin D deficiency because the active form of vitamin D is formed in the kidney. When the kidney is damaged, the 125 dihydrocalciferol, cholecalciferol will not be formed, or calcitriol will not be formed, and the vitamin D is helping in increasing calcium as well as phosphate. It is increasing the absorption of calcium as well as phosphate from the gut as well as kidney. So when there is a kidney damage, phosphate excretion will be impaired. So phosphate excretion is impaired, that's why we are having a high phosphate level. Vitamin D is deficient, that's why we are having a low calcium level. Due to low calcium and feedback mechanism, we are having a high plasma parathyroid hormone. And due to increased bone turnover, we are having high alkaline phosphatase. So all of that correlates. So it is due to the CKD, we are having a deficiency of vitamin D. Look at the options. Deficiency of 125 dihydrocholecalciferol, that's what I had explained. Deficiency of cholecalciferol, not cholecalciferol, it's the active form that is reduced, because that is the only step that is happening inside the kidney. Okay, so we are having a deficiency of 125 dihydrocholecalciferol. Osteomalacia, it is again vitamin D deficiency, and it is happening in adults. Okay, but here in this context, due to renal disease, it's a deficiency of 125 dihydrocholecalciferol. Pseudo hyperparathyroidism, no. Secondary hyperparathyroidism, no. Next question. A 63-year-old man presented with dyspnea and left basal chest pain over the past 2 to 3 hours. Symptoms were aggravated by coughing and movement. He smoked 10 cigarettes per day and had undergone treatment for thrombosis of left femoral vein 18 months previously. On examination, his pulse was 110 beats per minute and regular, and there were edema of both calves, more marked on the left. So, the patient has come with dyspnea, basal chest pain over 2 to 3 hours. Symptoms aggravated by coughing and movement. So more likely the chest pain is respiratory symptom associated. It's not a cardiac origin. He smoked 10 cigarettes and had undergone treatment for thrombosis of left femoral vein 18 months previously. So he had a history of DVT previously. History of DVT, acute dyspnea, chest pain. First thing that comes to your mind is pulmonary embolism. And also his pulse is 110 and there is edema of both calves, more marked on the left. So now also he has come with a DVT with a pulmonary embolism. We'll look at the ABG. PO2 is low, okay, consistent with pulmonary embolism. PCO2 is normal, pH is okay, H plus is 40, bicarb is 22. So hypoxia, dyspnea, chest pain. He had a previous history of DVT and now come with DVT and pulmonary embolism. Chest X-ray showing minor left basal atelectasis. What is the most appropriate diagnostic investigation? Chest X-ray can be normal also in a pulmonary embolism. It cannot be diagnostic. So what is the appropriate diagnostic investigation? The only investigation that is gold standard for pulmonary embolism is CTPA. CTPA. In pregnancy and all, if CTPA is contraindicated, you can go for a ventilation perfusion scan. But CTPA is gold standard. D-dimer, it has only negative predictive value. This question has been asked sometime in the previous paper. What is the role of D-dimer in predicting this pulmonary embolism? So it has negative predictive value. It has no role in positively diagnosing the disease. Negative predictive value means if the D-dimer is negative, you can rule out pulmonary embolism. You need not do a CTPA if you have a negative D-dimer because it has a high negative predictive value. But if D-dimer is positive, it is nowhere telling us that it is pulmonary embolism. It has no positive correlation. It has a negative correlation. Echo cannot directly tell us that it is pulmonary embolism. Ultrasound scan of lower limbs and pelvis will not tell us it is pulmonary embolism. It can a venous Doppler can tell us there is a DVT. That doesn't mean that the patient should have pulmonary embolism. So it is CTP. Next question: a 69-year-old man presented to outpatient clinic accompanied by his wife. She complained of disturbed sleep and said that her husband had become aggressive during sleep. She reported that he lashed out and screamed, and he had occasionally kicked her and fallen out of bed. These episodes could occur up to 4 times per night. On waking, he had vivid recall of the events but seemed unable to prevent them from happening. His BMI is 32. What is the most likely diagnosis? Options are nocturnal frontal lobe epilepsy, non-epileptic attack disorder, periodic limb movement disorder, rapid eye movement, sleep behavior disorder, sleep apnea. So here the criteria, like she had told that he's vividly remembering the events and he's becoming aggressive during sleep and he's screaming and lashing and kicking her out of bed, and it's happening time and time again, and it's unable to prevent them from happening. It's classical description of your rapid eye movement sleep behavior disorder or REM sleep behavior disorder. Okay. Sleep apnea means in an obese individual, they are having snoring and all. They can have increased daytime sleepiness. It's not like this. Periodic limb movement disorder, no. That is mainly limb movements. Here, the patient is aggressive and lashing and screaming, and also vivid recall of events. Okay. So that is REM sleep behavior disorder. Okay, the patient is having twitching and off-limb movement. They can be aggressive, but the classical description is they are able to remember vividly the events, but they are unable to stop. Actually, in sleep there are 4 stages, and the 4th stage and the deep stage of sleep is REM. That is when you have your vivid dreams, but usually you forget your dreams, right? And you are in the deepest sleep. But in this patient, that deep sleep pattern is disturbed, and they are, you can call it partially awake. They're not in that deep sleep during this REM cycle, which they should have been. That's why it's called REM sleep behavior disorder. And they can be aggressive and lashing and calling, and usually, the other partner will suffer from it. Next question: a 50-year-old woman with discoid lupus erythematosus presented with an apparent worsening of her rash despite treatment with topical corticosteroids and photoprotection. On examination, there were discrete erythematous scaly plaques with follicular plugging. What additional treatment is appropriate? So, discoid lupus with worsening of rash despite your steroid and photoprotection. There is scaly plaques with follicular plugging. The next line of treatment is hydroxychloroquine. Okay, if they are not responding steroid, give hydroxychloroquine. Next question: a 24-year-old man with a bluish discoloration of his body, lips and nails. He denied any past medical history. On examination, he had central cyanosis and a steel grey complexion. there were no other abnormal findings. HP 17.2, ABG showed PO2 13.6. Oxygen saturation is low, despite normal PO2 is having a low oxygen saturation, 90%. What is most likely diagnosis? Cyanotic congenital heart disease. He denies any past medical history. He is 24-year-old. There is central cyanosis, steel gray complexion. It doesn't go with your congenital heart disease, right? Hepatic cirrhosis, not likely. Methemoglobinemia, primary proliferative polycythemia, pulmonary arteriovenous shunt. So here in this question, HB was normal or slightly in the higher range, 17, and PO2 is low. PO2 is normal, but saturation is low. That means there is increased affinity or reduced transfer to the tissues. It happens in methemoglobinemia. Had it been a congenital heart disease, the patient would have even higher polycythemia, maybe an earlier presentation. So here it is more likely to be methemoglobinemia. It can be congenital or acquired. So we'll see the oxygen hemoglobin dissociation curve. We'll see what it means to be a left shift or a right shift. So this is a sigmoid curve, a normal curve. This is what happens normally. So for example, if there is a 50% saturation of oxygen to the hemoglobin, there is a corresponding PO2. Okay, this is the corresponding PO2. Okay, what happens in left shift and what happens in right shift? We'll see that. So in left shift means the curve is shifted to left. So in left shift, what happens is for the same saturation, we only need a reduced. So here, this is where 50% is corresponding. So for the same saturation, we only need reduced PO2. So even for a lower PO2, the saturation is getting attained. That means affinity is increased. When affinity of hemoglobin to oxygen is increased, it is binding to oxygen so much so that it is adamantly binding. It is so adamant and it binds, and it's hesitant to transfer that oxygen molecule to the tissue. That is why tissue will have hypoxia, just like we see in methemoglobinemia. The tissue will have hypoxia because the affinity for oxygen of hemoglobin is increased. For the same saturation, oxygen saturation for the hemoglobin, we only need a reduced partial pressure of oxygen. We'll see what happens in a right shift. See, this is what happens in a right shift. The curve is shifted to right. That means for 50% oxygen saturation, which is falling here, we need to have a higher PO2. So affinity of hemoglobin for oxygen binding is reduced. So there is increased delivery of oxygen to the tissues. Okay, so we'll see what are the cases where you remember either of these. Okay, so when there is increased PCO2, affinity of oxygen will be reduced because hemoglobin will be now trying and binding to the carbon dioxide molecule. So increased delivery of oxygen to the tissues. Okay, again, when there is increased H plus or acidosis, decrease in pH, there will be right shift. Increase in 2,3-DPG, increase in temperature, you will have a right shift. Left shift happens in the reverse scenarios, like in decreased PCO2, decreased H plus, decreased 2,3-DPG, and decreased temperature. Also, your fetal hemoglobin has a higher affinity for oxygen. There is reduced tissue transfer of oxygen. Next question, which cellular component contains double-stranded circular DNA? It's a fact-based question. It's mitochondrial. I'll talk a bit about mitochondrial inheritance. Mitochondrial inheritance, there are some diseases which follow a mitochondrial inheritance pattern. So you receive mitochondria only from your mother, okay? Not from father. Father only transfers the genetic material. The cell body, the cytoplasm and all comes from the mother. Mitochondria comes from the mother. So mitochondrial gene comes from only mother. So mother is only able to transfer these mitochondrial illnesses to the children. There are some questions which they ask, either they ask like what is the percentage that the daughter will receive the disease from the father. There is no way mitochondrial genes transfer from father to daughter or son, because mitochondrial material comes from only mother. So mitochondrial illnesses, only mother can transfer it to both their daughter or son. It is coming from mother. There, some examples are MELAS, MELAS, that stands for mitochondrial encephalopathy. Okay, it is MELAS, mitochondrial encephalopathy, lactic acidosis, and stroke-like disorders. Okay, so that is the acronym MELAS. And you have Lebert optic neuropathy, Lebert hypertrophic optic neuropathy. These are some examples of mitochondrial illnesses. Okay, so that only transfers from mother to child. Next question: an 85-year-old woman presented with breathlessness that had developed over previous 2 years. She complained of a cough that frequently woke her from sleep. She had been treated with radiotherapy for a cervical lymphoma 20 years previously. On examination, she was thin but had no abnormal physical signs. Her oxygen saturation was 95%, breathing air. Investigation showed basal fibrosis associated with dilated bronchi, but no honeycombing or ground glass change. What is most likely diagnosis? We'll look at the options: bronchiectasis, chronic aspiration, idiopathic pulmonary fibrosis, radiation pneumonitis, sarcoidosis. So she had received radiotherapy some 20 years previously. Okay, and she's having the symptoms over the past 2 years, and she's very elderly, and she's coughing that wake her up from sleep. She had been treated with radiotherapy, and she's thin, but there are no abnormal signs, and saturation is also okay. So this is chronic aspiration, especially in an elderly patient coming with cough, waking her up from sleep and all. And there is basal fibrosis also from recurrent aspiration. Okay, pulmonary fibrosis, there is no honeycombing or ground glass, so that cannot be. Radiation pneumonitis, not likely. Sarcoidosis, no. Bronchiectasis, that usually comes with a very high amount of sputum. That is not the case here. So it is chronic aspiration. Next question: a 20-year-old man presented with 24-hour history of drooling, a hoarse voice, sore throat, and difficulty in breathing. On examination, he had audible stridor. Lateral X-ray of neck showed features of acute epiglottitis. What is the most likely causative organism? A direct fact-based question: what is the commonest organism of acute epiglottitis in an adult? It is Haemophilus influenza. Commonest organism causing epiglottitis in an adult is Haemophilus influenza. Next question: a 68-year-old man was referred with muscle contractures following traumatic head injury 3 years previously. On examination, they were a left-sided torticollis. Which muscle is most likely to be responsible? So again, in torticollis, ipsilateral sternocleidomastoid is responsible. If there is a left-sided torticollis, it is left sternocleidomastoid. You may confuse between left or right. If there is a left-sided, it's ipsilateral. Left-sided sternocleidomastoid is affected. Next question: a 72-year-old man presented with loss of lower half of visual field in his right eye with no associated pain. He had type 2 diabetes and was treated for hypertension. Examination showed normal visual acuity with an inferior altitudinal field defect. Fundoscopy of his left eye was normal, and the upper part of right optic disc showed mild disc swelling. No frontal hemorrhages were seen. His BP was 160/90. What is the most likely diagnosis? So if this is our the retina, there is a lower half of visual field is affected, okay, and upper part of right optic disc is showing mild disc swelling. So the lower part of the visual field, the fibers are the sensation is received to the upper part, and lower part of the optic disc receive uh, images from the upper part. Okay, it is reverse. The nasal field receives information from the temporal field. The temporal field receives information from the nasal field. There is a crossover. At that point also there is a crossover, and the nasal fibers are also crossing at the chiasma. Remember that. Okay. So here lower half of visual field is affected. Upper part of optic disc is showing mild swelling. Otherwise fundoscopy showed normal features, no hemorrhage. Okay. We look at the options. Optic neuritis. No, optic neuritis, there will be some changes in the retina. There will be swelling and all. And it will be diffuse, more diffuse. Here, only lower half of the field is affected. Panuveitis, posterior communicating artery aneurysm. Posterior communicating artery aneurysm is like a painful third nerve loss. Remember it like a painful third nerve loss, posterior communicating artery aneurysm. There is no other features of third nerve palsy like ptosis and all. So that is not the case. Retinal artery occlusion can be. Okay. Retinal venous occlusion with retinal venous thrombosis comes like a painless sudden loss of vision. Arterial occlusion because here there is mild disc swelling and only some part is affected. So it can be a retinal ischemia and all. So it is retinal artery occlusion. Next question. A study evaluated effectiveness of a new analgesic in patients with painful knee osteoarthritis. Subjects were asked to assess their pain on a 10-point scale, both before and after 6 weeks of treatment. It is the most appropriate test to ascertain whether the treatment reduced pain. So it is like a 10-point scale, not an actual value, but we are like ranking the effect both before and after. Chi-square test, it's like a yes or no, whether there is improvement or whether there is no improvement. It is not an yes or no. You are assessing the also the degree of improvement, like in a 10-point scale. So it is not chi-square. Man-Whitney you test. You do it for more than 2 tests. One sample t-test. In t-test, it is actual value. Like uh, here, it is not an actual value. It is like a 10-point scale. You are ascertaining a rank or a or a degree of improvement. So it's not sample t-test. It's not a paired t-test. It's not a one sample t-test. It's Wilcoxon signed rank test. Okay, remember, like here it is a rank like thing. You are from 0 to 10, you are ascertaining a scale, and you are comparing it before and after the treatment. So it is a Wilcoxon signed rank test. Next question. A 36-year-old woman presented for review of her ventricular septal defect. She was considering pregnancy and echo was performed. What finding would indicate highest potential risk for a subsequent pregnancy? Associated AR, associated bicuspid aortic valve, high systolic pressure gradient between left and right ventricle, pulmonary hypertension, ventricular septal defect measuring half the aortic root diameter. So it's a fact-based question. What is most likely to compromise in pregnancy? It is pulmonary hypertension. Okay. Next question. A 43-year-old woman presented with 6-week history of pain and swelling of her fingers and toes. She had had a self-limiting episode of gutty psoriasis 15 years previously. Now she's having pain and swelling of fingers and toes. Her older sister had SLE. So we are getting confused between SLE, gutty psoriasis. So we'll look at the other investigations and all. Patient had diffuse swelling of her right index and left ring fingers and her left fourth toe. So many joints are affected, small joints are affected. There is diffuse swelling, right index, left ring, left fourth toe. Okay, and ESR is 18, rheumatoid factor is 10, ANA is 1 in 60. What is most likely diagnosis? Is it osteoarthritis, psoriatic arthritis, rheumatoid arthritis, systemic lupus erythematosus, systemic sclerosis? So small joint affected. There is diffuse swelling of the finger. Okay, and her older sister had SLE, but she's not having other signs of SLE. Like SLE can have synovitis, SLE can have rash. Okay, so and ANA is also not that high. ANA is not specific for SLE. Rheumatoid factor is low. Again, rheumatoid factor is not, if it is negative also, you can have rheumatoid arthritis. Doesn't mean it's not rheumatoid, but here it can be psoriatic arthritis. Okay, because there is diffuse swelling of the small joints are affected, multiple joints are affected. Okay, and she had also a self-limiting episode of guttate psoriasis previously. So it is psoriatic arthritis. Next question. A 72-year-old man presented with 6-week history of diffuse pain in his right arm and numbness in his right thumb. On examination, there was a reduced right biceps and sensory loss in right thumb. What is the most likely diagnosis? So many sensory dermatomal questions are coming. You have to somehow know the nerve, somehow know the dermatome. We'll see where the pain is. There is 6-week history of diffuse pain in right arm and numbness in right thumb. So the thumb is affected. Okay, there is reduced biceps. Biceps, it is C5, C6, C5, C6. We have to localize to one of it by looking other signs. It is thumb is affected. So and sensory loss in right thumb. So the dermatomal distribution I told you in the upper arm lateral part, it is C5. In the forearm, including the thumb and the the index finger, it is C6. The middle finger and all, it is C7. The medial part, ulnar side, okay, it is C8. Also your forearm, the medial side. Your arm medial side, it is D1. So here it is C6. We look at the option C6 radiculopathy. That can be because there is pain, there is sensory loss, there is biceps reflexes also lost. Carpal tunnel syndrome present with median nerve palsy doesn't present like this. There will be thenar eminence will be lost. There will be sensory loss in the radial 2.5 fingers. So that is not the case here. There is eighth thumb deformity. That's not the case here. Pankos tumor. Pankos tumor is the apical lung tumor. Can present with your Horner syndrome. Not the case here. Thoracic outlet syndrome. Not likely because that can compress the brachial plexus. But here only some part is affected. Ulnar nerve compression at the elbow. Ulnar nerve distributes to the medial 1.5 fingers, not the thumb. So it's not the case. It is C6 radiculopathy. Next question. A 55-year-old woman presented with vomiting and abdominal pain. She had a 3-month history of thirst and polyuria. On examination, of pulse was 90 beats per minute and BP was 90 over 65. They were reduced skin turgor. Sodium is 150, potassium is 3, calcium is 3.4, phosphate is 0.5, parathormone is 6.1. What is most likely cause of hypophosphatemia? So she is having vomiting, abdominal pain, 3-month history of thirst and polyuria. And BP is low, pulse is 90, there is reduced skin turgor. So she is dehydrated due to vomiting and due to vomiting. Okay, sodium is high, can be due to dehydration. Potassium is low due to vomiting. Calcium is high. Phosphate is low. Parathormone is high. So parathormone is high and calcium is also high. So it is not a feedback mechanism from calcium, because if it was a feedback mechanism from calcium, parathormone would have been low. Okay. So we'll look at the options. Decreased gastrointestinal absorption. What is it? Cause for hypophosphatemia. Decreased gastrointestinal absorption, increased bone resorption. Increased bone resorption. If it is increased bone resorption, phosphate will be low. Now, intracellular shift of phosphate. Reduced renal absorption of phosphate. Vomiting. So here there is vomiting, there is reduced skin turgor, there is thirst and polyuria, and now there is hypophosphatemia. We are being asked what is the cause of hypophosphatemia. It is reduced renal reabsorption of phosphate. So here PTH was high. So that will be the primary problem, PTH high. That's why PTH, what does it do? It increases calcium, reduces phosphate. Okay, reduces phosphate. And how does it do that? It reduces the renal reabsorption of phosphate and also from the gut. Okay, So that's why the problem is increase in PTH. So we'll have a high calcium, low phosphate. Others go with dehydration. And increased vomiting leads to loss of your potassium, the electrolyte disturbance and all. So that's why here it is reduced renal reabsorption of phosphate due to increase in PTH. Next question. A 67-year-old man presented with 6-month history of muscle rigidity and resting tremor. Diagnosis of Parkinson's was made and treated with ropinirole. What is the mechanism of action of ropinirole? A direct question from pharmacology. What is ropinirole? It's a dopamine receptor agonist. COMT or catechol-O-methyl transferase inhibitor is your entacapone, tolcapone. Dopa decarboxylase inhibitor is um, that is carbidopa. Dopamine transporter inhibitor is so dopamine transporter inhibitor, one of the drug that you use for obstructive sleep apnea, that is modafinil, comes under dopamine transporter inhibitor. MAOB inhibitor or monoamine oxidase inhibitor is salicylic and rasagiline. So ropinirole is a dopamine receptor agonist. You also use for restless leg syndrome. Next question. A 27-year-old man presented with 1-day history of fever and swollen right leg. 3 years previously, he had developed an urticarial rash, tongue swelling, and stridor after taking amoxicillin. So he had a severe allergic reaction to amoxicillin or penicillin drugs. On examination, he appeared extremely unwell. His temperature was 39.8, pulse was 130, BP was 66/38. So he's in a septic shock with a swollen right leg, probably cellulitis. So he had severe cellulitis of right leg and is in a septic shock. What is the most appropriate empirical treatment? So usually give penicillin drugs, but here the previous drug reaction, that too is a severe anaphylactic reaction to amoxicillin, will prevent us from giving penicillin drugs. So other option is clindamycin. It has an antitoxin effect because usually the causative organism of cellulitis is streptococcal or staphylococcal. So for that you have to give penicillin drugs. When there is a severe reaction, you can give a antitoxin effect, that is clindamycin, which is having that antitoxin effect. Ceftriaxone, cephalosporin also again will have that. If the patient had severe anaphylactic reaction to penicillin drugs, they would have reactions to ceftriaxone as well. Meropenem, gentamicin, piperacillin, tazobactam. For cellulitis, it is antitoxin effect of clindamycin which is preferred. So it is clindamycin. So that